Okay, well, welcome to Rxperience. I'm your host, Tom Hansel. We have given Chad Wurst the day off. I'm sure he's not taking the day off. I'm sure he's working somewhere, doing something with somebody. But nonetheless, we are going to do this podcast without him. And we have a special guest. You guys all know him, but I still want him to kind of introduce himself, give a little bit about his background. But this is our voice. This is our champion. This is the one that goes up on Capitol Hill and gets the bloody brow and dukes it out all day long. So with that, Jim Lewis, welcome to our podcast.
Yeah, thanks, Tom. Good to be here. And hi, everybody. So Jim Lewis here. Yeah, I'm ASCP's Chief of Policy. So I lead all of our federal, regulatory, and state efforts as it interfaces with government and oftentimes with payers. Before I've been on the team, it's a little surprising. Last month made 5 years I've been on the ASCP team. I joined the organization in 2021 after 6.5 years on Capitol Hill as a senior staffer to Congresswoman Barbara Lee and Robin Kelly. And then before that, I had some experience in the heavy manufacturing space with the aluminum industry, national security, doing nuclear nonproliferation and cyber stuff. And I also worked at a small PR firm.
Fantastic. And I learned so much from Jim. And today, we're not going to talk about IRA. We're not going to talk about pharmacy reimbursement. We're not going to talk about PBMs. But we are going to talk about something a little bit different, a little bit exciting. And I kind of I'm going to learn with you all. It's the way I look at this is something that could really shape the way long-term care pharmacy fits into the future of healthcare. And so for that, we're going to get started with this topic called MAHA Elevate. And so for those that don't live in Washington, for those that don't have your background experience, treat us like we don't know anything because we don't, or we know very little. So tell us a little bit about this model of MAHA.
Absolutely. So the administration, the Trump-Vance administration, is undertaking several extensive models, mostly through the Center for Medicare and Medicaid Innovation, which was established during the Affordable Care Act, so all the way back during the Obama administration in 2009. And this organization has broad authority across the government to impact healthcare, to test new systems and see what might work, with the goal of reducing overall spending from Medicare and Medicaid, as well as improving health outcomes for patients. And when I say they have broad authority, I mean they can waive every single provision of federal statute for any program except for PACE. So they can literally do whatever they want. And so we're seeing this administration try out a lot of new things. We've not really seen, despite having sort of a trifecta, we've not really seen a lot move on the congressional side. So this is really where the administration is making its play to have a legacy and impact in healthcare. And MAHA Elevate is sort of, so Make America Healthy Again, building up the Make America Great Again tagline from the Trump campaigns. Is really an effort to integrate into alongside sort of traditional medicine, whole lifestyle interventions that are aimed at improving chronic disease and management of the Medicare fee-for-service. So, we do know that Dr. Oz is a medical doctor overseeing CMS, and he has made it very clear that while he thinks these whole person functional lifestyle interventions are absolutely necessary to improving health, that they have to work hand in hand with traditional medicine. So I think that's a really important thing to put out there is they're looking at how do existing healthcare professionals step into this space and support people sort of beyond just the appointment with your doctor or your pharmacist, but really supporting you in managing your chronic conditions, living a healthier lifestyle. And so this is a massive program. I don't know how much you want me to get into it, but I mean, it's massive to the point where it's $100 million dedicated to this initiative. So they're putting their money where their mouth is.
Yeah, I mean, most of our healthcare system is really reactive. It's treating chronic diseases, and that's what drives most of our Medicare spending. But the core, I guess, issue or the core system that they're trying to do with this MAHA or MAHA Elevate is to really try to treat people, I guess, preventative more before that chronic disease kind of sets in, if you will. Is that right? Am I saying that right or think about that right?
Yeah, I would also say it's really about sort of delaying the worst impacts of chronic disease or helping people who are, maybe borderline diabetic, preventing them from crossing into that line of diabetes. That's really, probably the best example of this, but also looking at people who might have, high cholesterol. How do we intervene in their life in a way that we're able to manage their condition, maybe without medications or, without upping their dose of a medication? Because, as we know, as pharmacists, you all know that once you start one, it ends up often as a cascade. So this is looking at how do you intervene and either keep people where they are or improve it through sort of lifestyle interventions and functional medicine. Getting it's a little bit more than just getting people up and moving, right? Like we know that there have to be some of these other interventions, right?
Behavioral health, right? Like nutrition and behavioral health, yeah.
Behavioral, unfortunately, one of the things that's exempted is sort of direct nutritional support. Like you can't pay for people's healthy food, but if you have other funding, they're looking at how does food as medicine play into this? Can yoga reduce high blood pressure for some of these patients? This is, pretty exciting. And I think, we've seen the administration sort of go full bore with this. Some folks have seen Administrator Oz and Abe Sutton, who lead CMMI. They did a little yoga video that a lot of folks have found quite amusing. But I think, it shows too that this administration and the leadership over at CMS and CMMI are okay being a little uncomfortable, being a little different in putting themselves out there. If it can get
Dr. Oz was on TV for many years, so I'm sure he's very used to that. But tell me, CMMI, we hear that term a lot, but that's really the innovation arm of Medicare. Can you talk a little bit about? Everybody knows what CMS is for sure, at least in this space, but CMMI they might not be aware.
So absolutely, yeah. It's the Center for Medicare and Medicaid Innovation, and it was started all the way back in 2009 as part of the Affordable Care Act. So we're talking Obama-era administration, and this has been something that folks have talked about for a long time. Is how do CMS has so many rules, so many structures around it, who can get paid, how they can get paid, when they can get paid. And it's very difficult to be innovative when you have all of those structures. Mm-hmm. So CMMI has broad authority to exempt any existing CMMI regulation or law, actually. So they have sort of more authority than Congress, except for things impacting the PACE program. They're not allowed to touch PACE, but anything else. So they can, unlike CMS directly, because pharmacists don't have provider status, aren't considered providers under B yet, in statute, there's nothing that prohibits CMMI from paying a pharmacist for a fee for service. So I think for pharmacists, that's probably what's the most exciting and interesting thing here is these innovations can show the value of pharmacists while getting you paid in a fee-for-service, clinician-style manner that you really wouldn't have otherwise, because we're still working with Congress to advance the provider status legislation.
But value-based care nonetheless, and trying to get that kind of moving a little bit. But
that's a buzzword, Tom. But I've heard that term forever, and honestly, the question is, what is value? How do you measure value, right? And then also another question on the flip side of it is you can be the best clinician ever, but if your patient doesn't eat healthy, doesn't get up and walk, you can make all the interventions you want and provide all the value you can.
It's got to be the outcome.
What's the outcome? And so, I think folks keep talking about value-based purchasing. We've been talking about it for at least 20 years here in Washington. And I have yet
it's valuable,
to see...
Jim. That's why it's very valuable. No,
I have yet to see it really exist. But this is a goal in that direction, right? And really looking at patient outcomes as well.
Yeah, and I think that's probably more so true in, probably penalties or reimbursement when it comes to nursing homes or ACOs, and certainly, there is an outcome there if that patient gets rehospitalized, negative or positive, outcome, but they're certainly getting penalized. That patient does come back to the hospital. But let's get back to MHAA Elevate, Is this really going to be different? Is this really something that's going to be that we're going to be able to maybe hold on to a little bit? I know it's still in a pilot program, but it seems different, focusing on lifestyles interventions. But is this really going to be something that we can apply, or is it just another fun program to talk about, but it's not really going to go anywhere?
I think that's actually with any model, right? That's the question, right? And I mean, we've seen CMMI models come out that are, hey, we think this is going to work, and they end them a year early because it's not working. The costs are too high. It's not delivering the results. So the nice thing is that it's an incubator, right? We're really seeing how to test this out. And so, I think the question becomes, so I may have mentioned earlier, there's $100 million devoted to this effort, and there will be up to 30 proposals funded. So that's just quick back of the envelope math, that's $3.3 million for each one of these interventions. And when you look at these interventions, there's a couple of things they have to include, right? So one must incorporate nutrition or physical activity as part of the design. So that's a requirement. And then the other is the applicant has to identify a chronic condition or chronic conditions they're seeking to address. And I think for those of us in the aging space, I think it's really important that 3 of those 30 have been dedicated exclusively to dementia and cognitive decline. So there will be a few in this space specifically looking at that issue and those associated conditions. But it really depends on how good the application is, right? So folks who are doing this work right now are eligible to apply and show a scale. But I think, when you have 30 examples like this, you might get 10 that are really good ideas and another 20 that seem good on paper. And then, execution becomes a challenge, or, you start down the road and you realize you're not getting the intervention that you need, or you're not getting the results you need. So I think the hope is that this is really sort of the test kitchen, right? We're going to experiment. We're going to see what works. We're going to be able, because this is all modeled, right? There's going to be clear documentation of what the costs were to take care of this patient, what the benefits were. And then we can do that sort of cost benefit analysis. Or, in a perfect world, right? All 30 of these are fantastic interventions. They all work really well. We can then stack the cheapest and biggest impact ones. And I think that's really the goal of CMMI, is to identify these opportunities that make the most sense for patients and for the system, test them out, prove that it works, and then either go back to the regulators or CMS or go back to Congress and get what you need changed, so that you can do that moving forward, but that you actually have real data associated with it.
Right. So I know ACOs are going to be included, probably other healthcare systems, but let's talk about our audience here, long-term care pharmacies. Do you think this is something that they can get involved in? How do they get involved in? I mean, we're talking about clinical and outcome-based type of things, but again, pharmacies always seem to be that last piece of the puzzle that they forget about to the very end. But if you're listening to this podcast, you say, man, I want to get more involved in this. I want to be at the forefront of this. What would you tell pharmacies?
So you can. So I would say the biggest thing is get ready. Your letter of intent is due April 10th. But of the eligible applicants, I will say for those in the long-term care space, senior living communities are directly spelled out as entities that are encouraged to apply. So to apply, you're going to need your tax ID number, national provider number, CMS certification, or employer identification number. So there's really, anybody and everybody in that space is going to have an ability to apply. There is an encouragement that those who apply are at least enrolled in original Medicare. So if you're doing, let's say, diabetes self-management training under Part B, you're already enrolled in that system, so it's going to be a little bit easier for you. But again, CMMI has such authority here. If you've got a good idea to put on the table, that's going to get their attention, right? And I think they're willing to work with folks to make ideas work. Yeah. Unlike some of the others, like the access model, which is another model coming out of CMMI from this administration, that specifically requires that you have a physician medical director of the program. Gotcha. This program does not. So community-based nonprofits are available too.
Yeah, are they looking for like fewer hospitalizations, looking for like fewer chronic diseases, or like slowing the progression, or kind of what do you think that we should put as like the goal or the outcomes that we need to focus on?
Yeah. So, I mean, the goal and the focus here is whole person chronic disease prevention, right? Chronic disease prevention and management is the focus here. Applicants don't have to be clinical entities, but they must demonstrate the ability to have clinical oversight and deliver appropriate care and benefits, right? So that's sort of the exact language that CMS is putting forward. But they're really looking at, the combinations of psychological, nutritional, and physical interventions with personalized strategies. The model is designed to identify strategies that support conventional medicine, right? And there are sort of the big 5 criterias are whole person functional lifestyle medicine intervention that's designed to reduce cost, beneficiary recruitment and study design. So whoever is putting this together, CMMI is not going to help you get participants. You're going to have a mechanism in place to recruit participants in your study, organizational administrative capacity, data management capacity, and budget. And I will say, unlike other administrations, this administration has been very clear, especially with this program, that they want anybody who thinks they have a good idea who can manage this type of program to apply. So that includes faith-based organizations, community organizations. If you operate in multiple states, that's an advantage, but not required. So that's really what they're looking for, are people with the ability to recruit, people with the ability to oversee and deliver clinical care as needed. And if that entity is not a clinical provider, or if that entity is a long-term care pharmacy, you should think about applying for this. You should think about putting your name forward. Because there'll also be, the first letter of intent is due April 10th, but there'll be another bite at this apple for the 2027 cohort.
Okay. And I imagine dementia is a big, obviously patient base for us. A lot of our customers have whole dementia wings and whatnot. Is that something they should, prioritize, long-term care pharmacies?
Absolutely. So, the chronic conditions, dementia is included in that chronic condition. Cognitive decline is also included. And this grant has 3 grants specifically dedicated. So 10% of the grants doesn't mean they can't issue 4 or 5, but at least 10% of them are sort of tagged to be dementia and cognitive decline focused. So if that's the space you're looking at, it's not like you're necessarily competing against the folks who are doing, yoga for high blood pressure, right? You're competing against the folks who are coming in looking specifically at dementia, because that is a real call out to the system. Because we know what the cost of treating those patients are, and especially in the long term. So even if you can slow the patient's decline, support them living at home longer, or support them living in assisted living longer, right, that's going to show a massive decline in the cost of that patient's care, while improving their outcomes. So I would say, if you're working in that space, if you're doing memory care, for folks in an assisted living capacity, or even if you're doing it, in a nursing home, right? Sometimes the interventions aren't going to have the goal at a sniff, but someone may have a design that I'm not thinking of. But that community serving and that assisted living space, I would definitely say if you're doing something interesting and innovative and you're seeing good results, you should really think about putting together a proposal.
Yeah, and it sounds like partnering with one of your customers, or even going to people that maybe you're not servicing as a pharmacy, but you've got the creative, innovative, stability to be able to offer this type of program. That certainly seems like maybe even a marketing potential for long-term care pharmacies out there.
And I mean, there's money in it, right? Like, each of these grants could be up to $3.3 million to fund this. And I believe they are a 2 to 3 year window for the grant proposal. So, it's not like this is something you're committing to, like a 10-year commitment, which is what Access is. That's a 10-year program. So, this is a much smaller commitment in comparison to some of these other models being advanced by the administration.
Okay, yeah. So you mentioned Access. We talked about MAHA. I know there's Globe, Guard. What can you kind of help set that up between all those? There's other acronyms that is out there as well, but
there are a lot of acronyms out there. Yes. So the easiest way to think about it is, so Globe is part D as in dog. Globe, because it has a B, is part B, and Guard, because it has a D, is part D. Really what they're doing here is both of these are attempts to I know we said we weren't going to say IRA, but I'm going to have to say it for these ones. Right. The IRA was a Democratic idea. The Republicans don't like it, but it saves a bunch of money. So they're not going to get rid of it. And we've seen this administration continue to negotiate drug prices with the second and third rounds of manufacturers. Guard and Globe are looking to apply what this administration thinks is the appropriate mechanism, which is most favored nation. So tagging the cost and the payment from Medicare to the global standards, or not global standards is the wrong word, the global price amongst other developed nations. So looking at what Sweden and Germany and Japan and Australia pay, and it really is IRA. So the Globe and Guard are very focused on the actual price of the drug that the system is paying. So whether that be the Part D plan, a copay from the patient, they're out of pocket. But they're it's an end run of the IRA. But these are not small numbers, given that Guard is going to incorporate 1 in 4 Medicare Part D beneficiaries. 1 in 4. And it's going to be selected by zip code. So I would encourage long-term care pharmacies. This is one you're going to have to keep your eye on as those zip codes come out, because if you have facilities and patients in those zip codes, you may see pricing that is different than the IRA. Now, both of these models have invoked a little bit of ire, especially amongst the president's allies and more traditional Republicans, because the expectation, even from CMMI, is that they are both going to raise the cost for patients out of pocket. It might reduce the cost to the Medicare system, but patients will be paying a higher out-of-pocket cost. And so that's where there's a lot of noise being made. We don't have final design on these yet from the administration. There was a comment window, and ASCP was part of that comment period, but we're waiting to see the final guidance on these. But, this is 1 in 4 Part D beneficiaries.
Mm-hmm. Yeah. Well, I was thinking about when you were talking about, you said different zip codes, and, there's a lot of our concern and conversations about the rural areas as things evolve, as American healthcare system evolves, and you start taking primary care physicians out of those rural areas, and pharmacies kind of become the first level of healthcare in a lot of those rural areas. And so what are these programs do you think could help those rural areas kind of put that pharmacist kind of front and center, or that pharmacy front and center?
Not those programs, but there is another program.
Of course.
And this one actually isn't fully CMMI. It's actually going to be a separate office in CMS, and it was created by HR1, so the One Big Beautiful Bill. It was created by that, and it was the Office of Rural Health Transformation. And so shout out to the administrator, who's an MD, but he specifically said, I think people should think about paying pharmacists with this money. So, hey, we'll take a win.
God's ears, right?
But this is $50 billion. Billion with a B, right? Access and Elevate, we're talking the millions. This is $50 billion. And so basically what it is each state has to put together their proposal for rural health transformation. No matter what state you live in, there are rural areas in your state. So every state has applied for this. They package up their proposals and then they submit them to this office at CMS. And so one of the things we've been doing in partnership with NASPA and NCPA is trying to work with states to make sure that pharmacists are incorporated into this funding. And so it's exclusively focused on how do we transform, change, enhance, improve the delivery of healthcare in rural areas. While it's not CMMI, each of the states is going to do it differently. So we sort of have some natural experiments being set up here that will allow us some greater insight into, what has worked at the rural levels and what hasn't. Does paying a pharmacist was something we've all said will solve or help solve this problem? We'll have good data on the backside of this to show how that does, and actually measurable data, not just sort of back of the envelope estimations. So the administration is a little behind in issuing out these funding, but it's my understanding that states are sort of getting everything finalized for that to come out. But really, this now becomes a question of what is your state doing? And if your state is setting up something like CMMI, you want to make sure that you're in line for potentially some of these state models that might become available, because there's a lot, like $50 billion is a lot of money.
No, for sure. Yeah. You think about all the stuff and the different programs. I know we're talking about a lot of pilot phases, but, this is where ideas start. This is where the data gets collected at. But, not to be kind of devil's advocate, but I guess the opposite. Is there an example of something similar that started decades ago or in the past that then turned into real legit opportunities of real legit money that you can kind of think about that, hey, we have this program now because we went through a pilot program 20 years ago?
I would say the biggest and cleanest one to draw a line to is the, Affordable Care Act, right? Folks called it Romney Care because it was something that Mitt Romney enacted while governor of Massachusetts. It had the individual mandate requiring people to purchase health insurance or pay a fine. And folks looked at that, felt that it worked, and that has been expanded into what we now see as the ACA and the marketplaces. That's probably the most direct example. There's been a few things around the edges on prior authorizations. Unfortunately, I'm struggling to think of, and I'm probably not the best CMMI expert. You hear about the models that blow up and don't work more than you hear about the ones that do.
Well, it's with anything, pharma, we talk about how much drugs cost and those type of things, but we don't talk about is the 2,000 drugs that failed and never made it to market because of all the testing and trying to figure out, but something is going to come to market, from this. And, at the end of the day, if we're not trying to help our citizens do more than just take medications once they get the disease to help them prevent it, then we're really missing. We're really doing a disservice to our public as a whole.
Exactly. So I did just a quick one, and I will say we talked about this, right? Diabetes self-management training started out as a CMMI model. So I think that's another one that's a good example. Some stuff with ACOs, and that's a different issue. This administration also has a ACO pilot. There was a program in Maryland called Total Cost of Care, and that really looked at used a global budget for hospital systems to control total cost of care. And that really was a shift away from fee-for-service towards value-based purchasing. Now, that worked in one state, Maryland. But Maryland is a good microcosm, right? Mm-hmm. Baltimore and the DC suburbs are not the same place. You might have money, but you also have people who are living well below the poverty line. Then you also have that Eastern Shore that's insanely rural. There's not a long-term care pharmacy out that way. And then out west, you've got the panhandle that runs between Pennsylvania and West Virginia. The closest long-term care pharmacy to that world is in Cumberland, right? Maybe even in Hagerstown. I think that one may have closed. So, just knowing our space, there's not a lot of delivery of healthcare to some of these areas. So you've got hyper urban, very wealthy suburban, and then rural areas. So if something like that can work in Maryland, right, how do you transition that globally? Right. But then the challenge comes in with the state, right? You've got all these additional Medicaid county services provided at the state level that aren't federally counted and other things.
Yeah. No, but I think this makes a lot of sense, and it's exciting to think about opportunities outside of just getting paid for that medication cost or just getting paid for that dispensing fee. So pretend like you're Jim Lewis Pharmacy and you just heard Jim Lewis podcast. What do you do tomorrow? If you want to get into this, if you want to start expanding beyond just the medication delivery concept, what do you think the next couple steps are critical for a pharmacy to take?
The two things you have to do is step one, what is the thing you are doing for patients that is delivering the highest bang for the buck? What is improving their lives and reducing your cost? If that's home delivery, if that's special trainings for caregivers on how to administer medications, right? Whatever it is, or are you partnered with somebody else who's doing something innovative, right? There's this physician in town who's doing it. So one, figure out where your bang for your buck is. What are you delivering that you could take to CMS and CMMI and say, look, here's what we've been doing. These are what our preliminary numbers show. Let us scale. Two, partners. You're going to have partners to get this done because recruitment is on the applicant to do the recruitment. Who are you going to partner with to get the right people into your system? And those, I think, are the two things, right? Who are your friends and what are you doing that wins? And then from there, you're going to want to put that all together. And I always feel bad telling people, like I was emailing some of our pharmacies that I know do a lot of these lifestyle interventions. And they're like, oh my gosh, they're like, this is such a short window. And I'm like, they dropped this on Monday. Like I can't. And so for context, guys, it's Monday, the 30th of March today. So these came out like a week ago. And the deadline for the letter of intent is April 10th. So they gave us 17 days.
But you don't have to have it all figured out, right?
You don't have to have it all figured out. It's the letter of intent, but that's going to be, what are you testing, right? How do you win? And who are you going to work with to make this successful? The full application is due on the 15th of May. But even if MAHA Elevate isn't the right one for you, if you're not doing lifestyle intervention, you're not doing functional medicine, think about what you're doing that wins and think about who you could work with, because there might be state rural health transformation dollars coming your way. CMMI is going to be issuing more of these demos. They have $300 million unallocated for the next funding cycle. You can go to them with an idea. You can come to ASCP and we can partner with you to put together the idea and approach them with it. But if you can think about what are you doing that's delivering care and value to patients, that's improving their lives and saving the system money, and then you've got friends to work with. Again, like I said, we get 17 days on these letters of intent. You can start putting down the sketches of this and just wait for the opportunity to come up. But I think that's really what folks need to be thinking about for this is even if MAHA Elevate isn't exactly the right opportunity for you, there will be something else coming down the pipe. Yeah. And I think we spend so much time focused on the P&L sheet and delivering quality care and taking care of patients that are very complex and very difficult, that sometimes it's very difficult to get to the value-based component of this. It's very difficult to think outside the box, but that's the future. And if we're, there's an old saying in DC, right? If you're not at the table, you're on the menu. Right. Like if long-term care pharmacy isn't thinking about this, chain drugstores are. Independent pharmacies are. Physician practices are. Your ACOs are. Your facilities should be thinking about this as well. So how do you become part of the conversation? So my old boss on the Hill, she worked for Shirley Chisholm, and Shirley Chisholm was famous for saying, if they don't give you a seat at the table, bring in a chair, right? Bring in a folding chair. So how does long-term care pharmacy show up with its folding chair to be part of these conversations? Because if we're not, we're on the menu. We're going to continue to be on the menu.
Man, that's great advice, and it is. There is some kind of resistance because that's not what we've done for 50 years. We've dispensed medications, but because reimbursement's changing, there's multiple different things that we can do. We just keep praying that PBMs are finally going to get their rack across the back and they get straightened up so we can get our reimbursement back. But the reality of it is we've got to think outside of dispensing drugs. And this is just another, great example that's innovative, that's here, that, long-term care pharmacies should partake in. And we really need to break that bond of saying I can only get paid for dispensing, filling, sticking, labeling, and dispensing a medication. So I appreciate you bringing this to light, to this conversation. I think it's exciting, and it's really an overall shift of where healthcare is going. It's going holistic. It's going more preventative. And you made a little joke about what is value-based care, but I think the ultimate, even if that's not, we haven't experienced that, your true value, but it's really, we have to not stop driving towards better outcomes and preventable ways to avoid, that medicine, to avoid that disease state. And I think this is a great example of that.
Yeah, and that's where this administration is going. That's where the conversation has been going. You've got, like with anything, right? The most dangerous words in the English language are, we've always done it this way. Yeah. You've got some holdouts that are like, we've always done it this way. But look, IRA has decimated margins. Like, that's just a simple reality. There are no longer, and it's going to get worse. We're also, even outside of IRA, you're looking at most favored nation drug pricing from this administration, which is also going to impact that reimbursement number. So until folks get out of we've always done it this way, you're going to continue to be the victims for all of this. But on the flip side, the expertise lives within ASCP, right? The folks who are skilled at taking care of that 65 plus population, which is exclusively what MAHA Elevate is dedicated to, 65 plus. Those are the people with the expertise. These are the opportunities to put yourself forward and put your ideas and your successes on the line, prove them and scale them, because that's going to deliver the big results that folks are really looking for, whether it's preventing adverse events, preventing falls, keeping people at home healthier longer, reducing their pill burden and the number of medications that patient is taking, right? All of these things work together. These are things that pharmacists do. And at the end of the day, you're still cheaper to pay than a physician. So how, the folks that choose not to innovate, that choose not to be part of these conversations are going to continue to see their margins decline year over year over year over year as Medicare balances its books on the backs of pharmacy, which it has done time and time again. The folks that figure out the way to be part of these new systems, there's money sitting on the table right there for you to take it.
Yeah. And if you don't, someone else will.
Exactly. Like, they have to fund this money. It was dedicated by Congress. So they're going to do 15 cohorts, up to 15 applications for year one for this first cohort. And then if they don't fund 15 applications, let's say they only fund 13, there'll be 17 potential applications for 2027. So, folks, and you can also take the exact same 2026 application and resubmit it for 2027 if you don't get it. But this is absolutely an opportunity for people to be part of a big conversation that is a priority for this administration. And if you can show cost savings, now no longer you're just showing cost savings to your facility, right, and your customer. You're showing a benefit to patients. You're showing the patient's family and caregivers the benefit. Yeah. And now you're showing the government the value of investing in long-term care pharmacy.
Awesome. Man, what a great way to end. We will end with that right there. Great way to say it. Thank you, Jim, so much for not just bringing this subject up, but, really, again, as I said at the beginning of the podcast, fighting each day, not just for our reimbursement and our way of life, but, really fighting for the future of long-term care pharmacy. We appreciate you. We appreciate ASCP, and we appreciate our listeners. So tune in next time to Rxperience podcast, where your host, Chad Wers, will be back, hopefully with myself. So, Jim, any last words you want to leave everybody with?
The letter for intent is April 10th. So I would encourage folks to figure out, what it is you deliver for value, who you can work with, and get that letter in. I'll make sure Connor has the link. There's a write-up on ascp.com/news. It's the top item right there. So it has all of the information, all the links you need to get involved in this and to submit your application.
Fantastic. Thank you, Jim. Appreciate your time.
Good to see you, Tom. Stay safe.